Okay, good afternoon, good evening, everybody. Thank you for joining this webinar as part of a series on inherited Charcot-Marie-Tooth neuropathies organized by the EURO-NMD and the European Academy of Neurology and the European CMT Research Association, ECRA. Today we have a great pleasure and honor to welcome Professor Mary Reilly as a speaker. It is really a pleasure to have her talk today about outcome measures, biomarkers, and trial readiness in CMT. Professor Mary Reilly is a professor of neurology and head of the Division of Clinical Neurology in UCL Queen Square Institute of Neurology in London. She's a worldwide recognized leading clinician and scientist in the field of inherited neuropathies. She's a past president of the Association of British Neurologists and the British Peripheral Nerve Society, as well as the International Peripheral Nerve Society, and she's currently chair of the Guarantors of Brain. She's a fellow of the Academy of Medical Sciences and also fellow of the European Academy of Neurology. And I'm sure there are many more honors and awards that are too many to mention today. Professor Reilly has contributed really immensely in the field of CMT neuropathies. This is her main research interest, along with hereditary transthyretin amyloidosis. She has contributed to gene identification, the pathogenetic studies, consortium studies, natural history studies, and the development of innovative biomarkers, including imaging and especially MRI. And she participated in clinical trials in CMT neuropathies, but also in the development of new therapeutics. Thank you very much, Mary, for accepting the invitation, and we look forward to your talk. And thank you, everybody, again for joining.
And thank you very much, Cleopas, and thank you very much for the invitation to give this talk. So I'm going to talk about outcome measures, biomarkers, and trial readiness. And I always think that title sounds very kind of dry. So I'll try to make it a bit more how we are actually applying them in practice now and try to make it a bit more interesting. So these are my disclosures. I give an introduction, briefly talk about the current clinical outcome measures, talk about biomarkers, and throughout the whole process, I'll be talking about what is needed. So Charcot-Marie-Tooth disease is a disease we're all aware of, so I will not dwell on this, but just to say the classical disease is a hereditary motor and sensory neuropathy, but it includes the hereditary motor neuropathies, which are pure motor or motor predominant, and the hereditary sensory neuropathies that are pure sensory or sensory predominant. And we know there's many genes, which include, first of all, the genes that are involved with myelin, called CMT1, and those that are involved with the cell body and the axon, and that includes CMT2 and the vast majority of cases of HMN and HSN. And nowadays, we're very good at diagnosing these, and this is a paper from my group last year with almost 1,700 patients, where we looked at our diagnostic rate using modern techniques. At this stage, it was up to and including short read whole genome sequencing, but not long read. And there's a 77% solved case rate. So most patients get a diagnosis. We're much better at the CMT1, of course, which is well over 90% versus the CMT2 and the HMNs, which is sometimes still around 50% or sometimes even less. And we think about where we are with the treatment landscape. So when we have inherited diseases, we start, of course, with identifying the causative gene. From that, we do work to work out what is the pathogenesis of the neuropathy in a patient, and that involves a lot of preclinical work and a lot of different models. And from those, hopefully, candidate therapies arise, which can be initially used in preclinical models, taken to clinical trials, and then treatment. And we look at CMT, unfortunately, we have no treatments despite the 130 genes. But saying that, we have a huge amount of excitement going on. And this is a review from Davida earlier this or late last year in 2025, showing all of the different drugs that are either in trial or in preclinical studies for CMT. And just to give a few examples of trials, there is the trial of aldose reductase inhibitors for the autosomal recessive neuropathy caused by the SORD neuropathy. And that trial was designed as a 2-year trial, but was stopped at 1 year after outcome measures were looked at, and all patients are now in open label extension. There's a trial that's just finished, and the data has been looked at by NMD Pharma, and they were looking at a chloride inhibitor in various forms of CMT1 and CMT2. And I have an investigator-led trial that I'm leading at the moment, which is looking at serine in hereditary sensory neuropathy type 1. So there are trials ongoing. And if we take the more genetic therapies, if we take things like gene replacement therapy, antisense therapies, siRNAs, this is from Cleopas review last year, again showing all of the drugs that are in preclinical and some clinical. So there's a very small ongoing clinical trial in CMT2S due to mutations in IGHB and P2. And just late last year, Novartis, who have a drug which is an siRNA originally developed by DTX Pharma for CMT1A, have started a phase 1 trial in Canada. There's also a phase 1 trial in planning for a recessive form of CMT called FIG4 in the US. So we shouldn't really be talking about trial readiness because we're in the era of doing clinical trials. So this is the era of doing the trials. So all of what we've talked about in the past about trial readiness is now relevant, but of course it's an evolving area. And of course, as we do trials, we learn a lot more. So what are the specific challenges? Well, like any neurogenetic disease, preclinical validation is extremely important. I won't talk about that more today, but it is a huge barrier. So across neurogenetics, there are many drugs that have worked in the preclinical setting. So correct and detailed preclinical models are important. Delivery systems are extremely important because of the blood-nerve barrier and whether they should be given intrathecally or intravenously, etc. Again, a very important area. But I'm really going to talk about the clinical side. Most forms of CMT are very slowly progressive, not all. So developing tools for clinical trials are challenging. Many forms are rare, so the trial design is challenging. So the outcome measures for all of this in slowly progressive disease is probably the biggest current challenge to clinical trials and to ongoing trials. So what are the current clinical outcome measures? Well, before I talk about that, I'm going to mention this, the standardized response mean, because it's what I will refer to, just to give you a flavor of what we're looking for. So the standardized response mean is the mean change of an outcome measure divided by the standard deviation of change. And simply put, we want an outcome measure that will change a lot in a short period of time, like 1 to 2 years, so that we need less patients for the clinical trial. And what we're looking for is a large responsiveness, moderate to large, so around the 0.8 mark. And try to remember that as I go through it. So we've been thinking about this problem for many years. So 20 years ago in 2005, a group of us developed the CMT neuropathy score, which was an impairment score that took symptoms, examination, and neurophysiology into account. And it was an excellent score at differentiation severity, mild, moderate, and severe. But when we looked at clinical trials, and this was the original UK-Italian vitamin C trial, and we used this for a 2-year outcome measure. And as you will see, we know vitamin C didn't work in this trial, but if you look at the placebo arm, it didn't change over 2 years. And if you look at the SRM, it was 0.13 minimal responsiveness. So we know that the original CMT neuropathy score is not responsive over 2 years. We then work to improve it, particularly the sensory elements, and to rash modify it. So using this rash modified, this was available to do clinical trials. And around this time, we developed the Inherited Neuropathy Consortium, which has been running since 2009. And this is a consortium that was led by Mike Shai from Iowa. It was originally NIH funded for 15 years, and CMTA, the charity, have taken over funding it for the next 4 years. They've been funding it since last year. And really, this consortium was developed to try to look at the natural history and to be trial ready. So through that consortium, we've been able to look at the natural history of all the common forms of CMT, 1A, 2A, 1B, 4C, and 1X. And I've highlighted the two my group led, that is 2A by Menelaus Pippis and 1X by Chris Record. So in some of these, we have up to 8 years natural history data using the CMT neuropathy score, the rash modified. And I wanted to say one thing first. Look at CMT1A. So people argued that this does not progress in adulthood. But it does, but it takes a long time. This is the 6-year data with a very small amount of progression. So it is progressive, but slowly progressive. And if we look at the SRMs of all of these, we developed 2-year SRMs. And if you look at them, most of them are either minimal or small. There is only one, the 2A, which is the more severe form, that gets into the moderate. So our outcome measures are slowly responsive. And that's not because we haven't done a good job at developing them. It's because, by and large, we're dealing with diseases that actually progress slowly. So at the same time, people were beginning to think about children. And we know a lot of our forms of CMT start in childhood. So it is likely we need to eventually do trials in childhood. So in work led by Josh Burns and by David Herman, but Josh Burns and many people originally in the Sydney group, and also by Kyla Coronet in the group in Rochester. And Mike Shai was very much involved in leading this. There was a pediatric scale developed, and that had a responsiveness which was still in the moderate. It was still in the low at SRM. Sorry, I'm blocking it. I'm not seeing my slide here, 0.43. And there was also an infant scale developed. But what the pediatric scale did differently from our neuropathy score, it wasn't an impairment scale. It looked at functionally. It looked at things like dexterity of the hands, hand grip, myometry for plantar flexion, dorsiflexion, and a wide group of things like get up and go, doing a 10-meter walk, doing a stand up and jump, etc. And because that was very different, what Josh Burns decided is, why don't we develop a similar scale in adults so that we could actually have patients having this pediatric scale and move into the adult scale. The scale had to be modified a little bit in adults because there were certain things that people were not happy to do as adults with CMT, which is the long jump. So they developed what's called a functional outcome measure, which is most features in common with the pediatric score, but not all. And this was a reliability was done, and it was validated in a large study many of us are involved in called the ACT-CMT study, which is a study now which ran for 3 years and has now been extended for 5 years in 214 CMT1A patients. And this scale, as I said, was very like the pediatric scale. It took a lot of functional measures like the dexterity 9-hole peg test, stair climb, stance, etc. So it took the same type of things that were done in the pediatric score. Now, longitudinal data has not been published, but we did present the first 2-year data in the PNS in 2025. And at 24 months, it is not particularly responsive. Like the CMT-ES and even the ONLS, the progression is not significant at 2 years. So again, this is not the point of the scale, but particularly, this remember CMT1A, it didn't look at the other ones and the results may be different. So what about other measures? Well, people are very interested in patient-reported outcome measures, and there are particular difficulties in inherited neuropathies with these, because often patients have had them for a very long time and develop a way of living life with quite a good quality of life. So it's not like an acute acquired disease. So they are difficult in some ways, but a specific one for CMT was developed, the CMT Health Index, again by the Rochester Group. And this is an 18-item scale looking across physical and mental issues that would deal with quality of life. And again, as part of the ACT-CMT study, in the 214 patients, the CMT-HI ranges from 0 to 100, and it does correlate at baseline with the other functional measures and impairment scores, but there was no significant change over 1 year, and that's not a huge surprise. So to see a change, we probably have to be giving people something to treat their CMT. So we don't really know how these will react. And there has been the minimal clinically important difference calculated. So it's 3.8 of a 100-point scale. And in terms of pediatrics, a pediatric quality of life has been developed. Again, this hasn't been looked at longitudinally to date. So we have a huge number of clinical measures looking at impairment, looking at functional measures, and looking at quality of life. And currently, there are many studies looking at these in a longitudinal manner. And we are doing all of these, and I'll come back to this in a longitudinal manner across all the common forms of CMT. But we thought about this a number of years ago, and we began to realize as we collected data over the last 3 or 4 years of the clinical measures that they just were not responsive enough for the kind of clinical trials that are done over 1 to 2 years. So it was quite clearly we were going to have to change the way we were thinking. At the same time, we knew that the FDA and EMA always insist at the moment on these measures. So companies wanting to test drugs had no choice but to use them. So we wrote really an opinion piece, a number of us got together in 2023, for across neurogenetic diseases that are slowly progressive, but using CMT as an example, that we really needed to begin to think of surrogate outcome measures. Now, we have a lot of things we have to do to make these work, but I have no doubt that this is where the field is moving. And it was very interesting to see, MND, the SOD1 study, which one of the secondary outcome measures was the neurofilament light chain, and that has been enough to actually license the drug. So we do need these surrogate outcome measures. So what do we need from biomarkers? So what I think we need, some biomarkers are biomarker of target engagement. Is the target engaged? Are we hitting the right target? But what we're really interested in is bridgeable biomarkers of treatment response. So something that changes in the 1 to 2 years that will be useful in a clinical trial. And many companies want us to get them even more quickly so they have a kind of a proof of concept. But what we really need to do is show that these biomarkers predict clinical change over a number of years so that they can be surrogate biomarkers for a clinical trial. So if we have shown something, say, that changes in 1 to 2 years, but predicts change over 4 to 5 years from our natural history work, we can then propose it as a surrogate biomarker for clinical trial. And it's that bit that we haven't quite finished yet, and I think it's quite important. So of course, the easiest biomarker is a blood biomarker. And for peripheral neuropathy, we're looking for markers of axonal injury, we're looking for markers of myelin damage, and we're looking for markers of muscle damage due to the axonal injury, because often many forms of CMT are motor predominant. And of course, the classic biomarker is neurofilament. And neurofilament now, I think, is 87 diseases it is used as a biomarker for. But it's not specific to the peripheral nervous system. So it's a marker of both CNS and PNS axonal damage. It's a very stable biomarker, so it's attractive in that sense, although less attractive because it's not specific. And we actually looked at that in my group first in CMT, and we showed that it was increased in CMT compared to controls. But even though that was significant, there is overlap. But we did so, it correlated with the CMT scores. But when we looked at it over 6 years, there was no change in CMT1A, and that's not a surprise. So by the time you get to an adulthood, your axonal damage seems to be slowly progressive but constant. Now, we didn't look at children, and that may be different. We then need to remember that in certain other neuropathies, they're more progressive. So it is actually useful. So it may be more helpful in other forms of CMT or in children. And I always think of TTR amyloid. So this is a study we did in 2019, show that it was increased in patients with neuropathy versus controls, with TTR amyloid versus control, and specifically in neuropathy versus cardiomyopathy. And in the original trial of patisiran, the siRNA, it's quite striking that if you look at people who were treated, the neurofilament level came down and stayed down, whereas people in the placebo arm, the neurofilament level continued to rise before it came down when they're put in the open label extension, they got the drug. And subsequently, we've done some work saying the rise in neurofilament can predict the onset of the neuropathy, and that the reduction in neurofilament is actually correlated with the induction of the TTR suppression, which is a marker of target engagement. So I'm not saying neurofilament will not be useful in CMT. I think it's a very good marker to have in there. And until we have drugs that work, we will not know if it's responsive. And it has potential to be responsive in the more progressive forms and perhaps in children. Now, many other groups have worked on neurofilament. So I just wanted to acknowledge that and have found very similar results. So what else has been developed? Well, John Savern has really led the development of other markers, and he has identified a transmembrane protease serine-5 as being a specific biomarker for CMT1A, and has shown it's elevated compared to the other forms of CMT, and it's currently ongoing longitudinal studies in CMT1A against other clinical measures and biomarkers. He also identified microRNAs for both Schwann cells and for our muscles, and again, these are ongoing longitudinal studies, which will be very interesting. Other groups, including Rita Howard, have identified NICAM1, neural cell adhesion molecular 1, and GDF15. And there are a number of other biomarkers that have been identified. And with the increased sensitivity of our ways of measuring them, there are more that I know of that haven't been published yet. But as we stand today, other than neurofilament, we have no good longitudinal data, and we don't know whether they'll be responsive to change. It would be nice to find something responsive to change in natural history, because that would predict responsiveness if you were given a drug. But I think we need to have an array of these biomarkers we would look at, but it's a rapidly evolving place. The problem is it'd be nice to have something specific to the peripheral nerve. So neurofilament is not, but peripherin is. So I've been interested in peripherin as a biomarker of axonal peripheral nerves, and periaxin is a specific biomarker of myelin. And a work that we've done collaboratively with Mike Lunn's lab and Roberto Bellantini has been the person doing the work, and they've developed this for inflammatory neuropathies. We've had a very small pilot study looking now at CMT. And as expected, periaxin is elevated in the demyelinating forms such as 1A and X1 versus 2A and versus TTR, which is mainly an axonal neuropathy. And peripherin is elevated in the axonal forms, but also in X1, which is a lot of axonal damage, versus, say, TTR. And it's elevated in 1A, because they all have axonal damage. And they are all elevated in neurofilament is elevated. The log is different here, but they are all elevated in neurofilament. So these are promising, and we now have planned ongoing studies to look at this in more detail. I'm sure other people out there have different biomarkers, but the more specific we can get to the peripheral nerves, the better. And even though I think specific to genes are very helpful, particularly for target engagement, it's really good to have biomarkers that can be used across the diseases, because they can be very useful for clinical trials. So what are we doing? Certainly as part of this Inherited Neuropathy Consortium, we have the ACT-CMT study, which has looked at 3-year data and is now looking at 5-year data in about 250 patients. So we have longitudinal studies, which include now these biomarkers and some imaging biomarkers I'll talk about later. And then a 4-gene study looking at the other common forms of CMT with the similar studies ongoing. And other people I know are doing other studies of biomarkers versus clinical measures. What about skin biomarkers? Well, I think the big, win in skin biomarkers is PMP22. This has been known about for a while, that it is expressed in skin, but it was really this paper in 2 mirror models of CMT2 where John Savern led the really development and refinement of being able to look at PMP22 using nanostring and with good, basically, comparators to develop a very accurate measure. And it was very helpful because it showed response to treatment in an ASO in these. And he's actually, developed this further, and it is very sensitive as a marker. This will be a very good marker for all of the ongoing clinical trials in PMP22, that the aim of the study is to reduce PMP2 expression like siRNA studies. Now, David Herman has been interested in seeing, can we look at an outcome measure that looks at the response to treatment? And he has done a study many years ago, over 10 years ago now, looking at the Meissner corpuscles in skin. And this is someone normal, where you can see all the Meissner corpuscles. This is someone with CMTA who's mildly affected, you can still see some. And this is someone more severely affected, where they're absent. And as part of the ACT-CMT study, these patients are having these skin biomarkers done to see, will this be responsive? Now, we just don't know. In CMT, we think of the motor outcome measures more, but the CMT sensory involvement is very long-standing and is severe in patients when you do the neurophysiology, etc. But because they've often got used to it, they don't tend to complain of it as much. But it doesn't mean it isn't important. Moving on to what I think has been more successful is imaging biomarkers, and we've had an interest in this in my group since 2009. And we base this, and we've developed a program of study, and I wanted to acknowledge Jasper Morrow, Matthew Evans, and Caroline Doherty and Luke O'Donnell, who've all worked on this with me over the years. And basically, this is based on our initial studies, which were based on the fact that if you denervate muscle, and if you damage muscle in any ways with a myopathy, you accumulate fat. So in our initial cross-sectional studies, if you look at a very mildly affected patient with very mild involvement weakness-wise, they have very little fat. More severely affected patient, they have more fat, and very severely affected patient, you have severe fat infiltration. And I always look at this and think, we need to be treating patients much earlier. If we're going to treat patients when they've that much fat infiltration, we will not get any response, certainly in those muscles. And it goes back to whether eventually we need to be treating children. So our first study in 2016 showed that we could meet by doing a quantitative fat assay, we could measure the fat fraction accurately increasing over 12 months in CMT1A. And I have to tell you, I was a bit surprised we could. And it was about 1.2%. And this gave us an SRM of 0.83, right up in the large, and that you'd be able to do a clinical trial with about 90 patients in each. So this was one study, 20 patients versus 20 controls in one scanner in Queen Square. So we did another study. So we used Mike Shy's patients in Iowa. They did the scans using our protocol, and we tidied up the protocol to better positioning, and we did all the analysis, and we got the same results, actually a little bit better. And we then realized that a lot of patients are very mild. So if we took the patients that had just 10% fat, a little bit more severe, by looking at that, we could get a much better SRM. So if we self-select the patients, and we now know the approximate CMT-ES to get that. And since then, the French group, Sharham and Atriev, have done an identical type of study. They have developed a protocol also to look at quantitative MRI, and also have found almost an identical report, 1.36% last year. So it's been validated then over a number of people and by a different group. So what we've done since then is decided to roll it out internationally to 5 centres with all of the different common scanners. And we've shown it can be implemented in all of these. We've looked at 67 patients over 2 years as part of the ACT CMT, and again shown exactly the same, increased by about 1.2% per year. And again, an excellent SRM in the group if you look at 10 to 70%. So I think this has been shown now in repeated studies, multiple groups, multiple scanners. This is a very good response. Now, that doesn't tell us it'll respond to treatment, but it tells us it is the most accurate way at the moment of looking at change. But I always was worried about this group, because if the mildly affected CMT patients don't respond, that's also going to be the children. So if you step back and think of our patients, they have a lent-dependent neuropathy. So we decided to go to the feet. So we developed a protocol to measure fat fraction in feet. And this is a normal person, and this is someone with CMTA at 18 years, and there is fat infiltration. And we did a study over a year and showed we had the same excellent response using an SRM, and we got it up to 0.86, a very good responsiveness. And if you look at that, this is a normal person on the right, C, that if they have a normal feet, a normal fat, normal calf. This person has already got 20% fat infiltration in their feet, the CMTA patient, but still have only 1% in the calf. And this person is almost 50% in their feet and still have more or less normal calf, just 2%. So we now know that in certain patients, we have to go more distally. And then we thought, well, if it's lent dependent and we pick it up in CMT1A, what about the other common lent dependence of neuropathy? So we did a study in multiple patients over a year looking at 1X, 1B, and 2A. And the baseline fat fraction did correlate with all of our other markers, including neurofilament chain. And over a year, if you just look at some of them, we did see response. Now, 2A, of course, is the worst. 1B is a lot in the calf, but little in the thigh, and the same at X1. And we got the same really good responsiveness at either nearly 0.8 or above it. And also the thigh was responsive in patients with CMT2A, as you'd expect. So now we've shown across all the lent-dependent inherited neuropathies and in children, we can measure fat fraction over 1 year actually progressing. But it's hard work because you have to draw these regions of interest and it takes ages. So we then developed an AI program to do it for us, and we called that Muscle Sense. So we did another 12-month trial looking at the muscle sense versus the way we normally do it, which is human. And again, we found the same responsiveness, and we found that our AI program was as good as us. So now we use the AI program all of the time with humans doing quality control. But going back to what I said, does it predict clinical change? Now, the only study we've done this for is our original study that we did in 2016. It's ongoing for the other studies. And this study had only 20 patients, so we've only got 9 who were followed up for 4 years. When we look at this small study, the progression in calf muscle fat fraction does correlate with the progression of the clinical measures. And the change in fat fraction over 1 year predicts the clinical change over 4 years. So that's very encouraging. And as part of the ACT CMT study, where we did the MRI over 2 years, we now are extending the clinical measures for up to 5 years to just look at that and see, can we predict clinical change over 5 years? So muscle fat fraction is the most effective outcome measure to date. It can be done on all types of scanners and easily implemented in international settings because everyone's got MRI scanners. It correlates with the clinical measure at baseline repeated studies, and our pilot data suggests it predicts clinical progression. So our pilot data suggests it will be a very good bridgeable biomarker. We've ongoing studies to validate that, but the only way we know if it's responsive to treatment. So I've shown you that we don't think our other measures will be responsive to treatment over 1 to 2 years. We don't know that, but we don't think so. We showed in vitamin C it wasn't, but maybe vitamin C didn't work. But the only way we'll know is our fat fraction responsive to treatment over the time period we need, 1 to 2 years, is by finding that. Because if you have a drug that stops the neuropathy, how long does that take to stop the fat fraction accumulating in muscle? Is it weeks? Is it months? Is it a year or two? So in the hereditary sensory neuropathy trial I've mentioned, the nice thing about doing an investigator-led trial, and I'm incredibly grateful from the CMTA who funded this, is you can do the best outcome measure. You don't have to worry so much about industry, like industry do about FDA and EMA. So we are using a purposely developed lower limb muscle MRI fraction after doing a proper natural history study looking at all the outcome measures to identify this. And this is quite a complex outcome measure, which I won't mention now. But basically, all patients get thigh, get calf, and get feet. At the end of a year, we will look at the calf, which is what we're doing now. And anyone between 5 and 70%, the calf is used as the primary outcome measure. If they're less than 5%, we'll use the foot. And if more than 70%, we use the thigh. And this kind of severity appropriate anatomic level has also been done for muscles with FSHD. So it's emerging as a way for rare diseases of having all patients or most patients involved without having to confine your criteria for inclusion too much. So we've finished the trial and our data cleanup is currently ongoing. And then if we go back to the SWORD trials, this was 56 patients who had an aldose reductase inhibitor, and the original plan was to give it for 24 months, and the primary outcome measure was originally to look at the change in cortical level with change in clinical endpoints, including 10-meter timed walk. That was the primary endpoint. And then the secondary outcome measures included CMT-HI, which was a clinical patient-reported outcome measure, and the lower limb MRI. Now, the company stopped the study at 12 months when all patients had done 12 months because they found a significant reduction in sorbitol. They found the outcome measure, CMT-I had improved, and they found a correlation with a change in the clinical endpoints, which were not significant, but they correlated with sorbitol. That means some patients had finished the 24 months, but most haven't. Because if you finish a trial at 12 months, everyone has to finish it. So only 13 patients got the MRIs done at 24 months. So in the first 12 months of the study, all of the patients continued to progress, whether they were on the drug or whether they were on the placebo, they accumulated fat fraction. But the 13 patients, 10 of those were on treatment and 3 were on placebo. In the second year, those 10 patients, there was a marked slowing of fat fraction accumulation against the 1-year progression in those patients and in the whole group. And this is an example patient. Baseline to 12 months is the increase that you would expect, and 12 to 24 months, there is a stopping. Now, this is tiny data, 10 patients. It's, a study that this is just looking at that small number of patients. So it's only very pilot data, but it might tell us in this form of CMT that the fat fraction stops progression between 1 and 2 years. Now, we don't know if this will be the same across other ones. We don't even know if it'll be the same in the others. But it's the first time we've had a hint at where this might be happening. And, it's a shame the study didn't have everyone finish at 24 months. And we very much hope that a further study, which I know people want to happen, will happen in this form of CMT. So what I've done since then in our group is we've got a new study to really just get this in a way that it's much more easily implemented and done. So we have a new study which is called Transform CMT, which is funded by Muscular Dystrophy UK. And this is a study where we're developing what we've called a AAA MRI protocol, which is an advanced AI accelerated protocol. Again, this is going to get down to 30 minutes. It's going to be optimizing for processing. So we've done, as I said, AI for the segregation. This is going to AI the whole thing. It's going to have much more assessing the interscan reliability among scanners in patients rather than just in controls. So we hope that this will be something that will be very useful for the field. Even though we know our current one works, we do appreciate it's time consuming and it's expensive. But what about going to the source? So people have said, well, muscle is the end. Wouldn't you like to look at nerve? And we'd originally looked at nerves many years ago and shown, which is well known, the CMT1A nerves are bigger than control and bigger than those ones that are already big in CIDP. And Chatterton's group in Marseille have done some lovely work looking at quantitative assessment of the nerves using magnetic resonance imaging. So nobody's at the stage yet where they've got something that's responsive over a year, because it is quite challenging and whether you have to have a different one for axonal and demyelinating. But we shouldn't forget the nervous where it's at. And as we develop 7 Tesla, etc., we should remember that we should keep developing this, and we and others are doing that. And then there's ultrasound. Now, ultrasound has been developed by multiple different groups, and it has been shown to be useful at looking at the size of nerves and to be useful at looking at fat fraction in muscle. But to date, there hasn't been any good studies showing its responsiveness over a year or two. And again, it had the advantage of being very easy to do, and particularly in children, but the disadvantage that it is pretty operator dependent. And the thing about an MRI, you capture an image, which you can work at. This is slightly different. It is very much operator dependent. So I think it's an open question, not a closed question, an open question of its usefulness as a bridgeable biomarker in clinical trials. But there are groups exploring this, which is excellent. So as I said at the beginning, what we need from our biomarkers, they need to be target engagement when needed, and there's multiple other target engagement biomarkers out there. We need bridgeable, and we're getting there. We're getting to the stage where we have bridgeable because we're getting to the stage where we've shown the clinical progression. And if they are, they'll be able to act as surrogate endpoints. And of course, we need clinical trials to show whether they're going to be responsive. So we need drugs that work for patients, but we also need drugs that work so that we know what to use when we're doing clinical trials in all our other patients. So it's every time we do a trial, it's extremely important we capture that data and we work with companies to have that data available so we can scrutinize it carefully afterwards to use it for the benefit of the whole CMT community, not just the rare form that might be having a clinical trial. So I'll finish by saying, are we ready? And we need to be, because the clinical trials are ongoing. So this is not a question that we really need to ask. I think there's been huge progress in the last decade, and the progress is driven by the development of therapies. There's nothing like a therapy developing to really drive progress. We have trials ongoing. Now, companies are kind of forced to use clinical outcome measures that we feel slightly uncomfortable about a lot of the time because we know they're not responsive. But I've kind of got a bit more sanguine about this, particularly after the neurofilament in the NMD field. As long as an outcome measure that is the best one going is a secondary outcome measure, I think that's a really useful. As long as we, I don't want to do a trial that doesn't have at least the best outcome measures we have available in it, even if they can't be primary. I get that we have to prove that they predict clinical change to be primary. So I'm open to that, but I think it's very important. So when we look at a trial, I always look to see, is the science robust? Should we be doing the clinical trial? We owe that to our patients. We really need to make sure the science is robust. But also, is this something that's been done well enough, clinical outcome measures, that we feel will give an answer? And if it doesn't meet those criteria, we won't get involved in the trials. The delivery systems are critically important, and a huge amount of work has been done on that. And Cleopas has done a lovely review of this in the last year. The outcome measure and biomarker work is critical. So you can't get away from needing good natural history studies. And there's a whole range of other outcome measures being looked at. The wearables are an up and coming area. Multiple studies going on in CMT. Multiple studies showing they're very good at baseline, very good compared to clinical measures. But again, we have to look at them over time to see will they be sensed enough for the time that we need to do clinical trials. Natural history studies remain absolutely critical, including running for clinical trials. They remain absolutely critical. But I do think we will need bespoke trial designs for some CMT types, especially the rare ones. We're going to have to think differently about how we do them, because there is no such a thing in my books as a CMT that's too rare to do a clinical trial in. It's our job to find a way of doing it. So I'd like to finish by acknowledging my group in Queen's Square. There's multiple people here whom I've mentioned. This is the clinical group. I always show the physicists here because the physicists and the computer scientists are never available for pictures. They never like themselves being in pictures, and many other people involved here. And of course, you cannot do any work without funders, and there's multiple funders, which I'd like to acknowledge. And also, just to say what's really great about this webinar series, it's done by ERN, EAN, and ECRA. And the INC is something that's been really, really important. So is the PNS, so is the CMTR. I'm sure I've left someone out. But CMT and inherited diseases can only be solved by international collaborations. And, it's to my huge regret that we left Europe, because I sadly see lots of collaborations going on, which I cannot be part of now. So we're always open for collaborations. The only way we'll move forward is finding ways to collaborate. Science should be bigger than politics. And if we don't do that, we let our patients down. Thank you very much.
Thank you very much, Mary, for this fantastic talk and giving really, all-inclusive overview of all biomarkers and all the developments, from the natural history stage to now really seeing them being implemented in clinical trials. So I think it's very exciting. And I think it became clear that perhaps not a single biomarker will do the job, like not a single outcome measure. So we have to have multiple in each trial. And my question is, have you considered the possibility that we could combine multiple biomarkers, like a logistic regression model, and try to combine their predictive strength
Yeah.
and use them as one predictor?
Yeah, I think that's a very interesting point. So I think it's interesting. A lot of people don't like compilation biomarkers. So even the CMT neuropathy score, CMT form, CMT peds, FDA may, they much prefer the cleaner the better. So I think there is a bit of resistance against that. I think what we need to do is finish the data. So what we're doing as part of the longitudinal studies now is looking at the blood biomarkers, including exploratory ones, looking at the imaging biomarkers, and looking at all of the clinical outcome measures, biomarkers, and quality of life. And I think we just have to see where we are with these. And it may well be there has to be ones that are combined. Very attractive to have ones that you can do across forms of CMT. It's always attractive because you learn a lot from those and they're implemented easier. But I think with some of the blood biomarkers, unless we get phenomenal ones for peripheral Schwann cells and peripheral axons, if we get something that's really responsive to those, it'll be challenging to have ones that can be not be across, they'll be just one specific. So I think that's a very good point, and we may well end up doing that. I think what we need to do is we need to be very involved with anyone doing the trial design to at least say, 26, this is what we think is best. We know it probably won't be in 3 years' time. And also to encourage people, like I would say with the patisiran trial, they didn't publish or do the neurofilament in the initial study, but they'd saved the blood. So when the data come out, they were able to go back a year later and look at it. So I think saving blood and biomarkers and skin, whatever you want, from any trial or natural history study, that's how we certainly did our neurofilament in CMT1A originally, because we'd saved all the blood from a natural history. So I think, saving, the biomarker banks, so however you do them, and I know it's always difficult to get funding and space and all kinds of things, but I think that's where the answers will come from eventually. But I do think I don't think in many years to come, we'll be using primary clinical outcome measures for these trials that need to have 1 to 2 years for the primary. I think we'll have moved to surrogate. We'll have primary ones as well, but we'll move to surrogate. And if we haven't, I think it'll be a difficult place, because I think people, we can't do trials with thousands of patients. And if you do trials with 20, 30 centers, which people are doing, the more centers involved, the more difficult it is to have exactly the same quality control of the outcome measures. We know, my 2 or 3 colleagues that we do it here, we look at our scores from the last time, we think, oh my goodness, am I getting weaker? Is he getting stronger? Like say Alex and I or Matilda and I. So we know between each other, even if we retrain every 6 months, there are differences. So I think, obviously training people in clinical outcome measures is really important, but also diluting it over multiple is not great. So I think the outcome measures that can have least number of patients are probably going to be really important, at least, for people developing drugs. They want to be able to do a go, no go. They may want to do very small trials initially and then move to much bigger. And it'd be really nice to have an array of stuff we can say, this is really likely to predict you going into a phase 3 or not. And we're not there yet.
Yeah, I think it would be nice if we had different responsive biomarkers at different time points. So,
Yes.
clearly, if you're treating a demyelinating neuropathy, you would expect to see a remyelination indicator like periaxin, perhaps,
Yeah.
much earlier than when you expect to see an axonal regeneration
Yeah.
indicator like neurofilament or your MRI fat
Sure.
fraction.
Sure.
It's expected that it would take much longer. So I think perhaps it is, and I don't know if you have considered to just, agree on a guideline for how clinical trials in CMT neuropathies
Sure.
should be done and what should be
Yeah.
included, and that
Well,
should be binding for the
yeah, well,
industry.
it is evolved. I mean, our statement 2 or 3 years ago, the 23 paper, does have most of this in it, at least to a certain extent. I mean, the other thing I think about, and there's a lot of work now ongoing in children because, I think a lot of CMT, we try them in adults first. Not all. Some of the more serious ones will go straight to children. But I do think a lot of the damage is done in childhood, and the outcome measures need to be different because they're still growing. So your axons are growing, your myelin is still developing. So what was the last one for the brain? Is that we're adolescents till we're 35 now, seemingly, according to the brain studies published very recently. So we've got to allow for that. So it may be what we're doing in adults, we need to evolve, and it might be easier to measure stuff, but it might be easier to do it in children because it might be that we can pick up changes quicker. But we have to get all of this in children as well. And we know it's harder to do certain studies in children. It may be for our MRI, we can do it from 5 up without sedation. So without sedation from 5 up, but it's one of the reasons we're making it shorter and shorter. So one of the reasons we're trying to get shorter and shorter is that. But I do think the childhood, I think we really need to do a lot more work in the outcome measures in the childhood area because, that's when a lot of CMT starts. And certainly the more severe forms, we've got to treat them in childhood.
And that's the age we're going to more likely see more response to treatments where you have
Yes.
less irreversible pathology. And I don't know if I don't see any questions. Elizabeth, I'm not missing any questions in the Q&A box, right? I don't see any. Just want to make sure I'm not missing any
There's
of these.
only comments for now.
Okay, only comments, and everybody is very happy, and everything was clear. Just one more question. So, what do you think is the chance of getting the regulatory authorities to approve treatments based only on response of biomarkers and secondary outcome measures? I mean, we've seen it with motor neuron disease, but it's a much more severe and lethal disease.
Yeah, I think that's true, Cleopas. But some forms of CMT are very, very severe. I mean, I have a number, of patients who have really severe disease. So I think that is true. I think it will happen. I think we've some work to do first. But I think if there was a secondary outcome measure, if you think of, go back to tafamidis. Go back to tafamidis in MET30 TTR. The primary outcome measure was negative.
Yeah.
And that got licensed in multiple countries. It was a different, they did detention to treat, there was different ways. But, there are multiple examples of the primary outcome measure not being met and other things going. So I think, I would feel that may happen. And I think what seems to be not resolved is when, companies go to FDA or EMA, sometimes they get told they want one outcome measure, sometimes like with the TTR trials, they were allowed to use 2. The quality of life, some of them, and an impairment outcome measure together, the NIS score. So I think it does seem to be the advice differs. And part of that is our job to get the data out there. But we're doing it at the same time as trials have started. We don't want to stop the trials for patients. We don't want to say we need 10 more years. Give us 10 more years to have sorted this problem out and then come back to us. That's not good for patients. So It's why I think one of the things we really need to do is any information from clinical trials is not lost. So I think, and if we can put as many of our outcome measures in exploratory in clinical trials, it does mean even if a trial is negative, I know that'll be disappointing for everyone, but it won't be lost data.
Yeah, I mean that's crucial to to maximize the use of any data because this is a very valuable and patients participate, and at least even if it doesn't work, we should use the data for make progress. So I see a couple of questions now. So there is one from Nesta Vole. Can CMT2 affect the nerve in the eye and ears?
So it certainly can affect. So CMT2A, you have optic atrophy in some patients. It's more with some mutation than the other, unquestionably. Very likely that this is due to the fact that it's a mitochondrial fusion protein. And we know we know from mitochondrial disease that the optic nerve has high energy demands and is very demanding. Hearing is a very interesting question because the nerve for hearing, the auditory nerve, etc., and the vestibular branches have both CNS and PNS myelin as part of them. They become involved in multiple forms of CMT, not just 2A. Some forms is very early onset hearing. It tells you it's likely to be, you see it with SH3-TC2 due to CMT4C. And there is some evidence that even in CMT1A, subclinically often there is hearing involvement. So yes, you can get those nerves involved with different variants.
Thank you. There is one more question from Robert Pryor. Hi, Mary. Great talk. Do you view CMT1 and CMT2 trials differently in terms of progression over a year or two?
Say that again, just answer the question.
So Robert's question is, do you view CMT1 and CMT2 trials differently in terms of progression over a year or two?
So first of all, I don't talk about CMT1 and CMT2 anymore, given up. I talk about the gene. Because if you look at your electrical studies, the intermediate is getting bigger and bigger and bigger. So the 38 meters per second is a fantastic for cutting off 1A from the others with 2 or 3 exceptions. There's a couple of milder patients. So some very severe forms of the demyelinating are clearly very low conduction. But so many forms of CMT overlap that I think about CMT and the gene-specific outcome measures. So I don't think of 1 and 2 different. I do think there are markers of axonal damage and markers of myelin damage. And I think the amount of those you would use in various forms of CMT might differ for the outcome measures. But most forms of CMT, the progressive damage is the axonal damage. So that's what you're trying to measure by most of our outcome measures. Now, it may be that if we start treating CMT1A much earlier in children, we'll be more interested in the myelin. But since we know the deficit is axonal, that won't be a clinical outcome measure. It won't be a clinical outcome measure that's picking up the myelin issue.
Yeah, because all clinical deficits are really caused by the axonal degeneration. I mean, you can have damaged myelin and have no clinical manifestations.
Although, Cleopas, it is interesting. I mean, I was thinking about this the other day. It's just a thought. So if we think of CMT1A, and it is absolutely astounding to us clinically that you'll have slow conduction, fairly homogeneous between the nerves. You do it 10 years later, you do it 5 years. As long as the axon is still working, the conduction velocity does not generally change much. And then it disappears. So when the axon is gone. So that's one thing. Whereas lots of other forms, the conduction velocity gets slow as well. So I was thinking the other day, why do we get slow conduction in CMT1A? We've always assumed it's demyelination. And if you look at nerve biopsies, it's de and remyelination. And yet, if you look at nerve biopsies in more mildly affected CMT1A, I've often done them if I've had diabetes as well, they're different. Some nerves have some myelin left, some nerves are demyelinated, and some are onion bulbs. Sometimes it's loads of onion bulbs, but they have short internodes. So why doesn't the conduction velocity get slower, and why isn't it patchier? Is it actually the length of the internode? What is determining the velocity? So I'm beginning to think that actually even the velocity might not necessarily be reflecting the myelin, because I can't understand why it's not more patchy and why it doesn't change, not with the clinical deficit, but just on its own, because the amount of myelin you're losing increases. We know that if you do biopsy at different ages, and we know with it. So that's quite interesting. I don't think we've answered that question. And if that's true, we may have to think completely different biomarkers if we're going to treat children of myelin damage.
Yeah, I mean, certainly the length of the internode will affect the velocity, and for sure there is a mixed population of myelin.
So do you see in your mice, so if
Yes.
you look at them progressively, do the conduction velocities slow? Do they get slower?
No, they don't change.
They don't change.
It's similar
So why
to
is that,
humans.
Cleopas? So I've been thinking about this for the last week. When I saw a patient last week, I just thought, how come I've never really thought about this properly?
Well, I think myelination is a dynamic process, and if you have demyelination and remyelination, and that can be a continuous process.
Sure,
So
but then the
you
conduction
always have a
velocity
mixed
should vary.
you have
They
a
shouldn't
mixed
stay the
population.
same.
Yeah, and it's also at different levels. So it could be proximal, distal. So it happens at different levels, and it's more difficult with the nerve conduction velocities alone.
Exactly.
There is a couple of more questions. Why some people get CMT and MS?
So there's no evidence that CMT and MS are more commonly associated with each other than by coincidence, because both are not uncommon diseases. So there are forms of CMT that you can get myelin changes in the brain, rare forms that can look like MS, but repeated studies, even though there's been people publishing it, the repeated large epidemiology studies, and I have maybe 10 patients with CMT MS and MS, different forms of CMT. So as anybody will, if they have a big enough population of CMT patients, but they're not linked pathogenetically. It's just that they're both not uncommon diseases. Like diabetes and CMT, they're not uncommon diseases. Now, whether CMT is worse if you have diabetes as well is a much more difficult because there's been different, studies about that. And I have to say, I've seen a few people recently with CMT1A and diabetes, and if you have 2 hits on your nerves, it does accumulate. You do get more damage. But whether it makes it so, so the MS and CMT to date, there's no evidence that they're related pathogenetically.
Yeah, thank you. Thank you for clarifying. So there is one comment from Maurizio De Antonio about the velocities. In 1B mice, nerve conduction velocity reduces over time.
Well, very interesting.
Maurizio,
so that's interesting, Maurizio, but Maurizio, why don't they in 1A? We need to think about that. I just think it's something it's just striking. It can stay 14, 14, 14, 2-3 decades, and then it's gone, and the axon's gone.
Yeah. One more question. If you can offer one advice in terms of management of CMT what would you recommend?
Well, that's very difficult. So certainly we've no pharmacological treatments as of today that are proven to work for it. I mean, I think most patients with CMT, the biggest problem is their feet. I know hands can become a problem earlier on. So I think it's find the right orthoptist and get your feet in as good a shape as possible. And when you're younger, do what your physiotherapist says. Keep your Achilles tendons, supple. Keep it and keep fit and don't put on weight. So, it's your feet that matter because that's what causes most. But I know there's loads of other problems. But, I would say while we're waiting for treatments, optimize your foot care and your orthosis. And it hugely varies what people are offered all around the world. And I know that. And I know it hugely varies what people are told. And when to have surgery, we don't actually know we don't know when, because surgeons, some phenomenal surgeons, but a surgeon is an apprentice. They learn a certain technique and they do that. So comparing techniques is really difficult. You can't tell a surgeon to do a different operation on every second patient. It just doesn't work because that's not what surgeons do. So we have a lot of work to do with that. But I would say finding the right orthosis, the right people to help you keep mobile and keep fit and try not to get overweight. Try to keep those under control is what I advise people. We try to help people with.
Definitely. Yeah, thank you. There is a comment from a patient. Thank you, Professor Reilly. Is George McKay. As a person with CMT, this lecture series is really very reassuring that we have such an expertise on our side, even if I don't understand the details. So thank you for joining in any case.
Thank you.
Patricia Avellino, thank you, Professor Reilly. Interesting lecture. I look forward to seeing you next week.
Some of my patients are on this, obviously.
Audience from your clinic. Okay. They keep coming. Maybe one couple more. Most of them are just to say thank you. Daniel Montero, hello. I read that a healthy feeding is important to face CMT. I'm interested in consuming antioxidants. However, I also read that we should not consume more than needed. In that case, what's the amount you recommend and which antioxidants?
So I don't recommend antioxidants at all. There is no evidence that anything. I always say to my patients, are you on any stuff? There is no evidence that adding in any supplements, etc., if you're not deficient. Clearly, you should have a healthy, balanced diet, like everybody. And obviously, if you're a meat eater and you become a vegetarian or a vegan, you need to make sure your B12 is okay. So there's certain things you should do, but there's no evidence that any supplements to date make any difference. So we don't recommend supplements. And actually, certain supplements can be damaging, depending on how they're made, etc. So I'm very careful because drugs are made to certain standards, but a lot of supplements are not made to the same standard. So it's sometimes, depending on where you get them or where you buy them, it's sometimes difficult to know what's in things.
And sometimes too much of a good thing can be toxic also.
Exactly.
Like vitamin 6.
Yes, it's too much of a good thing too much of a good thing in life is never good, is it? They say.
Great. Okay. Final question, although I don't think it's easy to answer. It's from Alexandra Barranca. She says, awesome presentation about CMTs. With variants of unknown significance. My genetic testing, I have both of them with VUS, CMT2B2, spinocerebellar ataxia with axonal neuropathy. I'm not sure what the question is, but
So I suppose I could comment on variants of unknown significance. I don't quite. So one of the problems is people nowadays, almost everyone gets a panel of genes done. So variants are found in genes. And the first thing you do as a clinician, you see that and you say, is it any relevance? Because all of us, every panel is done with a variance in these genes. The question is, are there relevance? There may be ones that are not relevant and relevant. And then unknown significance usually means it depends. That we call them, they can be hot, meaning they're likely to be relevant, or they can be cold and they're not. And then it's a matter of if they're seen in multiple families and shown in families to actually segregate, that is, people with the disease have them, it increases the chance of them being the real gene. But sometimes it takes a long time to get multiple families. And we've all seen families, we thought we had something. I saw a family last week that I had to say the gene we found 12 years ago was probably not the correct gene, because we now have evidence that it mightn't be. So we try to be careful in what we say, whether we think it's definitely the cause or not. And I think this is a particular stress for patients now, because clinical trials will enroll people where they have to enroll people where they think the gene is the causative. So VUSs are going to become a bigger problem. And to be fair, AI, bioinformatics, and functional studies all are helping to solve this. But it's an ongoing issue. And I think it absolutely needs a combination of geneticists, bioinformaticians, and clinical expertise and basic scientists to solve.
Yeah, exactly. Thank you very much, Mary. I think we reached the hour. It's only thank you notes in the chat. So it was really a fantastic presentation. Thank you so much for your contribution and for the excellent talk and for all the discussion. Thank you everybody for joining, and we'll be with you again next week.
Thank you very much. Thank you, everyone.
Thank you. Thank you, Mary. Thank you, Kiropas.
Thank you, Elizabeth. Bye.
Goodbye.
Thank you,